The next is liver. So chronic liver disease or even acute liver disease. So when there's an end stage liver injury or disease that can cause altered mental status or coma. So how does that happen? So you already know about liver in detail. Here is just a quick review. So liver failure can cause symptoms and signs of liver failure, which are going to be lower extremity swelling, abdominal swelling, and shortness of breath. So these, again, you can see that these are basically your fluid overload or fluid volume overload symptoms. So really, liver in itself is not doing anything. It's basically a result of too much fluid in the body cavities or extravascular fluid. So this is how people have these symptoms and signs, plus fatigue. So fatigue is the number one symptom here. But anyhow, so their precipitating factors or their underlying causes of liver failure. The number one cause in the United States is alcohol and hepatitis C. So hepatitis C and alcohol are the biggest cause of liver failure. And then we have some additional causes, for example, drug-induced liver injury. People call it DILI now. So drug-induced liver injury. And then autoimmune hepatitis is another cause, and primary biliary cirrhosis is another cause. So of these five, the first two are the most common. So here is just a little bit more in-depth discussion of symptoms and signs. So how does it happen? So basically, when people have liver failure, liver can become cirrhotic, and cirrhosis is just a pathologic diagnosis. So basically, this just means nodular fibrotic liver. This has nothing to do with clinical features necessarily. So people can have cirrhosis and have a vast variety of symptoms and signs. It doesn't necessarily correlate with cirrhosis. So the diagnosis of cirrhosis is based upon a pathologic picture, either biopsy or ultrasound or something like that. So anyhow, whenever people do develop cirrhosis, basically there is fibrosis, so liver is not working right. So these are the things that result from that. So people have portal hypertension because now there is too much fibrosis, so pressure will increase in the portal bed. So this is just like a mini hypertension in one part of the body, and as a result of that high pressure, varices will develop. So basically esophageal varices will develop. So just like varicose veins in the lower extremities because of high pressure, there are esophageal varices that are developing because of portal hypertension. And from these three things, what happens is that because of cirrhosis itself, because the liver is fibrotic, it's not functioning, so synthetic functions of liver will decline. So as a result of that, people will have elevated ammonia levels. So they are not going to be able to get rid of ammonia because liver is very efficient in eliminating ammonia, which is a toxin in the body. So people will have high ammonia levels, which will work as a toxin and will cause encephalopathy. So these people, just because of this, can go into encephalopathy, lose their mental status, and finally go into coma. Also, because of portal hypertension, because there is just so much pressure, these people develop ascites, and so they have abdominal swelling. And then ascites, when it gets infected for whatever reason, sometimes spontaneous infection, and we don't even know clearly what caused the infection, but I would say common sense says that because it's just so close to the intestinal area that any bacteria can just basically ease into the acidic fluid and cause spontaneous bacterial peritonitis. These people will come in with severe abdominal pain, swelling, and then of course they have a lot of tenderness. So this scenario will be a spontaneous bacterial peritonitis. So just remember that whenever people have liver failure and ascites, because of that, it can complicate to become spontaneous bacterial peritonitis. Then so before we go on to the further sequelae of varices, let's look at the hypoproteinemia. So because liver is not functioning and not synthesizing, protein level will drop, so there will be edema because of low protein, and then also vitamin deficiency because of low protein levels, because people are not able to hold on to vitamins. So remember that edema in the body can result in from different mechanisms. So in addition to hydrostatic pressure and osmotic pressure, low protein levels will also cause edema. So that's another reason for massive edema. And then there will be clotting factor deficiency. So you remember that clotting factors are synthesized in liver. So because there is not enough clotting factors, it will cause prolongation of INR. These people will start bleeding because of that. So INR will be high and they will bleed easily. So that's another unfortunate phenomena. Then also because liver is going to because of decreased synthetic function of the liver, there will be thrombocytopenia. So, and thrombocytopenia or low platelet count usually happens because as a result of cirrhosis and portal hypertension, there will be splenomegaly too, and splenomegaly will result in entrapment of all the platelets, and these people will have low platelet count and they finally start bleeding. So platelet count is an extremely important marker when we are looking at prognosis for cirrhosis. And then finally you have some of the less common or important features with cirrhosis. So you have gynecomastia possibly, then you have spider angioma, caput majus. These are just small things that happen because of capillary dilatation. And then you have jaundice. Again, this is not a very common feature with cirrhosis, so don't jump to this or don't just start thinking that jaundice has to be present. Usually it's actually not present, at least in the early stages, and this happens of course when there is excessive bilirubin because of decline in liver function. So the third thing about varices is that whenever people have because of severe portal hypertension, they have of course esophageal varices. These varices will of course spontaneously bleed too. So these are the people who will come in with hematemesis or either melena or lower GI bleed. So they have a lot of gastrointestinal bleeding, and this, if they get to this point, this is usually a very poor prognostic marker when they start bleeding from varices, and that's usually an indication that they are not doing well. So that's something to keep in mind. It's an emergency situation, and when you have liver failure or you're suspecting it and you have any of these features present, of course the labs to do would be, you will do liver function test, BUN, creatinine, and metabolic panel, so all of these things. And then if you are suspecting spontaneous bacterial peritonitis, you will do peritoneal tap, and that tap will basically show an exudate if it is an infection indeed. If it's not an infection, it's simple ascites, the tap will show transudate fluid. So transudate or exudate, depending upon whether the infection is there or not. And then the biggest reason for encephalopathy in any patient with liver failure is there are 3 different things that can precipitate encephalopathy. So these 3 are also very important to keep in mind because these are the things that we should then prevent from happening whenever we have a stable patient with cirrhosis. Otherwise they will go into encephalopathy very quickly. So what are those? So it's BID or BID. So it's bleed. So any bleeding, so for example variceal bleed, can precipitate encephalopathy. Infection basically anywhere in the body, but spontaneous bacterial peritonitis will also precipitate encephalopathy, and then multiple drugs can do it too. So therefore if somebody has cirrhosis, even a very stable form of cirrhosis, and they're doing very well, we should not give them drugs that can cause precipitation of cirrhosis and result in encephalopathy. And those drugs are mostly prescription drugs, so they're not illicit drugs necessarily. So a lot of these are basically your NSAIDs, your acetaminophen, your benzodiazepines, and of course alcohol is the biggest culprit. Then finally, the treatment for liver failure, of course you will treat the underlying cause. You will, if once the cirrhosis has set in, you will use diuretics. You'll try to control the portal pressure, avoid any further injury. Liver transplant is the ultimate treatment, and in order to do that, these days people use MELD score or CHILD score. So these are the scores used to figure out if a patient is a candidate for transplant or not, but I'm not going to go into the detail here, but the basis on which these scores are done are bilirubin level, INR, and creatinine, and there are some other things too, but that's beyond the scope of this talk. So finally, if you most of the time whenever you have encephalopathy and or upper GI bleed or lower GI bleed because of hemorrhage and because of encephalopathy, people will of course go into either altered mental status or hypovolemia, and they go into coma. So that is the mechanism behind coma resulting from liver injury or liver failure. So whenever you have somebody who shows up with coma, if you backtrack, these things will be present in the history. The labs will show that, or all precipitating injuries will also be present in the history. The next is gastrointestinal causes of shock or decreased level of consciousness and ultimately causing coma. So the biggest thing is gastroenteritis, and usually I say pediatric and geriatric, because usually adult population will recover from gastroenteritis more easily, because we are more there is just more capability to kind of retain fluids when you are an adult. But pediatric patients and geriatric patients are not able to bounce back so easily, so it's particularly important to recognize alarming situations when you are dealing with them. So these people have diarrhea and vomiting, dehydration, hypovolemia, and then finally hypovolemic shock and coma. And symptoms and signs, of course, will be that there will be history of gastroenteritis, signs of dehydration, skin turgor will be low, so of course there is massive vasoconstriction that's causing it, and causing decreased capillary refill, and then the blood pressure will be low, heart rate will be up, and again that is happening because of compensatory mechanisms. And then urine output will be low, because the body is going to try to retain all the fluid in the body to maintain blood pressure. But also this can result in another complication of renal failure, so these people will end up with kidney failure if they are not treated promptly. So if it's a young patient, usually we look for tears, and then they also may be very somnolent. So the labs to draw would be, in addition to metabolic panel, you can do urinalysis. So again, like we talked about this previously, in case of gastroenteritis causing severe dehydration, specific gravity will be very high in the urine, urine osmolality will be high, BUN creatinine will be high, and FeNA will be low. So everything high and FeNA will be low, or fractional excretion of sodium will be low. Treatment, of course, no surprise here, IV fluids and supportive treatment. And then finally we have septic shock. So usually this is focus infection, so people come in with an infection, so whenever it's not treated they can go into sepsis. So that is the reason why we like to treat infections. So focus infection can result in systemic infection, which can cause pro-inflammatory proteins, and there is widespread tissue injury because of that. And then because there is so much tissue injury, tissues in different parts of the body want to get rid of all that toxic material there. So what they do is they just ask blood vessels locally to dilate, and that's a compensatory mechanism. So because of vasodilatation, there is reduced systemic vascular resistance, there is hypertension because there is not enough blood pressure to support, and then there is a lot of tachycardia because your heart is going to try to compensate. And then finally these people will go into shock. So therefore you can see that these features will be very important to recognize and then diagnose septic shock. So whenever you have shock or septic shock, of course, in addition to doing antibiotics, a massive amount of fluids will be necessary. So although these patients already have vasodilatation, so there's a lot of fluid in the peripheral circulation, but they need more and more fluids because all of this needs to get out. So they need to flush out all the toxins. So fluids, and then antibiotics are needed. And then the next one, so we're almost there. So hematological causes of shock, the biggest one is DIC. So hemorrhage can of course cause hypovolemic shock, and then of course all those things that you already know, but then DIC is one thing. So in DIC there is an underlying condition that will result in either activation of intravascular coagulation, which will cause platelet consumption, low platelets, consumption of the coagulation factors, so high PT, APTT, fibrin deposition and fibrinolysis, so high D-dimer, high fibrin degradation products, which all of this will result into impaired coagulation, and it will result in bleeding, or it can also directly cause endothelial damage, and then because of the fibrin deposition it can cause thrombosis, so there is organ ischemia. So you can see that bleeding and thrombosis are occurring concurrently. So this is really a very interesting, although very unfortunate phenomena. So usually when people get to this, it's a very grave situation. So it's a very dire circumstance. It's very hard to reverse this. but it's very important to recognize it. So this, basically, simply put, this is where people bleed in the body. There is bleeding where it shouldn't, and there's clotting where it shouldn't. So in small organs or small parts of the body, there is thrombosis, so organs start to develop ischemia, and then massively there is going to be bleeding because there is so much consumption of clotting factors and platelets. This is another slide showing the pathogenesis of DIC, but anyway, I think you are very familiar with it already. And then in DIC, the common causes are going to be, so whenever you're seeing somebody with sepsis, or they're already sick with malignancy, recent trauma, or obstetrical complications or conditions, so these are very important too, for example, placenta abruption and things like that, or if there is intravascular hemolysis because of transfusion reactions. Any of these 5 things can cause DIC, and then there can be more too, but these 5 are most common. And then of course clinical features will be that clinical scenario will be consistent with whatever happened before, so a cascade of events, untreated infection, abruption, recent transfusion, or anything like that. So whenever you are managing a patient with any of these problems, if they're not managed well, not necessarily because of your fault, but just because their body just didn't turn around, they can go on to develop DIC. And of course, clinical features, along with this historical feature, they will have some symptoms and signs too. So they will be bleeding all over. They have end organ failure, end organ damage due to thrombosis and ischemia, and ultimately, because of hypovolemia, they go into coma. The final complications after coma or with coma are they get kidney failure, shock lung, hepatic failure. So basically everything in the body starts to collapse. That's what happens.